look at whether there is a household or a close TB contact in the previous 12 months, and then a scoring system that allocates scores to signs and symptoms in both algorithms, and chest X-ray features in algorithm A. And it's just important to note that the scores are different in the two algorithms because they are really based on modeling data. So in algorithm B, the score allocated to specific symptoms will be different than the score allocated in algorithm A because there's also chest X-ray features to be scored. So you can see then the scores are there with the different signs and symptoms and the specific chest X-ray features. And if the sum is then together more than 10, those children would have a decision to start TB treatment. In terms of the performance of the algorithms for the scoring part, just the scoring part, the part in yellow in the algorithm, the sensitivity was set at about 85%, and the specificity that results from that is quite low. 37% in algorithm A and 30% in algorithm B. And the steps above the scoring part have really been added in an attempt to improve performance. And it's important to note that these algorithms have only been internally validated, and external validation is currently ongoing. And in collaboration with the TDR, the research program on tropical diseases, we have developed a research package to contribute to the external validation of the treatment decision algorithms and to really harmonize research efforts from different groups. And then ultimately, those data could potentially be pooled for an analysis to really evaluate these algorithms. We have a lot of studies going on, and we will hear from one of the principal investigators from Nigeria, Dr. Chuko, a bit later. And as you can see on this map here, we have a number of studies ongoing, many of them in Africa, but also in Brazil and Indonesia. And we expect a total cohort size of about 20,000 children. So this is something that we keep track of, and hopefully by next year we will be able to analyze those data. Then the next topic about the shorter treatment for children with non-severe TB. So we have a recommendation based on the SHINE trial, which was a non-inferiority trial that looked at shortening treatment to 4 months, comparing that to the standard treatment of 6 months. And that led to this recommendation that in children and adolescents between 3 months and 16 years with non-severe TB and without suspicion or evidence of multi-drug or rifampicin-resistant TB, a 4-month treatment regimen should be used. And that treatment regimen is exactly the same, consisting of the same medicines as the standard regimen. So it's the standard first-line medicines with the continuation phase reduced to 2 months. And you can see here the definition of non-severe TB. That's defined as peripheral lymph node TB or intrathoracic lymph node TB without airway obstruction or uncomplicated TB pleuroeffusion or paucibacillary non-cavitary disease confined to one lobe of the lungs or less and without a miliary pattern. And of course, children and adolescents who do not meet the criteria should receive the standard 6-month regimen or the recommended regimens for severe forms of extrapulmonary TB. And then the use of ethambutol in the first 2 months of treatment is recommended in settings with a high prevalence of HIV or with a high prevalence of isoniazid resistance. Now, in the operational handbook, the Module 5 handbook, we have criteria to assess eligibility for this 4-month regimen. In the SHINE trial, the main criteria were based on chest X-ray findings, but we do realize that um, not all children may be able to get a chest X-ray in all settings, especially in more rural settings. So we have considerations based on the availability of chest X-ray as well as diagnostic testing. So if both are available, the eligibility will be based on chest X-ray features and an expert MTB RIF or ultra result that is negative, trace, very low or low, and the child should also have mild symptoms that do not require hospitalization. Now, if you don't have access to chest radiography, but you can test a child, then the criteria, the consideration for eligibility will be based on those expert results and mild symptoms that do not require the child to be hospitalized. Now, if you don't have access to either chest X-ray or testing, and this only applies to children aged below 10, those would be children who have isolated peripheral lymph node TB or pulmonary TB, again with mild symptoms that do not require hospitalization. So it is possible to base this on clinical criteria, and we will hear some implementation experiences as well from Zambia in this webinar. Now, these mild symptoms that I was talking about, these are worked out a bit in more detail as well in the operational handbook. So there should not be any danger signs, there should not be any asymmetrical or persistent wheezing, and no signs of extrapulmonary TB other than lymph node TB. And the child should also not have severe acute malnutrition, respiratory distress, high fever, severe pallor, restlessness, irritability, or lethargy, which all point to more severe disease. And then if you have a child or an adolescent who are started on the 4-month regimen without a chest X-ray, you should be followed up every month, and you would expect symptoms to have resolved within a month. And they also expect it to be well at 4 months. And that would be including a nutritional status that is very similar to what before they fell ill. And of course, if there's any doubt, you can continue TB treatment for 6 months if there's no response after 4 months. But these children really need to be evaluated for drug-resistant TB, but also for non-TB related disease and adherence as well. Just to mention in terms of the chest radiography, there's a very useful resource developed by the Union, which is the Diagnostic Chest X-ray Atlas for pediatric pulmonary TB, which has a lot of details on how to assess severity on a chest radiograph. So that's very useful. And then we do know from reporting that countries are reporting data every year to WHO. We've seen quite limited implementation up to 2024, and many countries have been consulting widely to determine practical guidance on how to assess eligibility and severity of disease in programmatic settings with or without access to chest radiography. And again, our colleagues at TDR are developing an implementation research package to also get more information about the adoption, the fidelity, feasibility, acceptability, etc. of this 4-month regimen. So this is where I'm going to end, and we will get some further experiences from Nigeria and Zambia, and it will be nice to hear from our colleagues from those countries how they have implemented. So I would like to acknowledge our colleagues from the Global Tuberculosis Program. Thanks very much for your attention.
Okay, thank you, Sabine, for that really comprehensive overview on the treatment decision algorithms and the shorter TB treatment regimen for children. So next we'll hear from a colleague from Nigeria, Dr. Ochuko Orioke, who is a public health practitioner and researcher with 17 years of experience in TB, HIV clinical care and program management. Important to note is that Dr. Ochuko has played a pivotal role in coordinating integration of TB, and he has coordinated the National Child TB Week that led to a significant number of children with TB being identified in Nigeria. He is also a co-PI for the study to evaluate the effectiveness of the WHO treatment decision algorithms for pulmonary TB in children in Nigeria. Over to you, Dr. Ochuko. Hello, your mic is mute.
Thank you.
Okay.
Thank you, Maureen, for that excellent introduction. I hope you can hear me.
Loud and clear.
Okay, so it's been mentioned, I will be taking this presentation on behalf of the Veduta study team and the Nigerian National Tuberculosis and Leprosy Control Program. I want to start by appreciating the organizers of this events for finding us worthy to make this presentation, and also to appreciate my national coordinator, Dr. Labaran Shehu, and also our current acting national coordinator, Dr. Clement Adesigbe, for the opportunity. I'll be presenting on Nigeria's experience providing a national perspective on implementation of the treatment decision algorithms. So I'll go with this outline by way of background. Low child TB notification has been a major challenge in Nigeria. For many years, we struggled with finding children with tuberculosis. And just to say that in the year 2022, we notified barely 35% of the estimated 58,000 children with TB in Nigeria. And we have a very ambitious national strategic plan for tuberculosis spanning 2021 to 2026. With the goal of accelerating efforts at ending the TB epidemic in Nigeria by ensuring access to comprehensive, high quality and patient-centered, as well as community-owned TB services for all Nigerians, irrespective of age, gender, their place of residence and all that. So it was really worrisome for us that despite a number of interventions that we've introduced prior to 2023, we still had limited case finding in children. So when WHO came up with, I'm talking about the adaptation process now for the treatment decision algorithms in Nigeria. Following the release of the WHO guidelines for pediatric TB in February 2022, we saw it as important for us to really quickly come up with a process of adapting key recommendations from that guidelines. And one key recommendation that we adopted, initially we adapted, was the use of the treatment decision algorithms, the A and the B, as has been mentioned by Sabine, for pulmonary TB diagnosis in children less than 10 years. Unfortunately for us, TWG meeting came up around that time. So it was like a good opportunity for the members of the TWG group, TWG, to really brainstorm. So we brainstormed and we adapted the treatment decision algorithms. When I say adapt, it meant that we did not take the recommendation completely. We did some adjustments, particularly as it relates to those children with those children with risk factors, talking about the HIV positive, those less than 2 years, and those with severe acute malnutrition. We did not consider that step in our initial algorithm. And after the adaptation, we quickly came up with a rapid advice, which we disseminated to all stakeholders, including the state programs and all partners, since July 2022. Following that release of the guidelines from the World Health Organization, there was a call by WHO in conjunction with a TDRO for external validation of the treatment decision algorithms. And Nigeria was one of the countries that responded to that call, and it led to the implementation of the VEDUTA study. VEDUTA is an acronym for validation of the effectiveness and diagnostic utility of the treatment decision algorithms. And it was a study group that had investigators from different centers across the country. Our primary objective was to evaluate the performance of the TDAs against the standard definition, and the secondary objectives were to determine the feasibility, acceptability, and impact of the TDA's use on TB notification. So these are the algorithms. I won't bore you with this because Sabine had already explained what it's all about. The algorithm A, where there is chest X-ray, and the algorithm B, where there is no chest X-ray, especially for PACs that are manned by nurses and other general healthcare workers. So talking about the methodology that we used for the VEDUTA study, the study design was a mixed multi-center interventional single-hand diagnostic evaluation study. Our population for the quantitative part was children less than 10 years with presumptive TB that were visiting healthcare facilities. And we also had a healthcare worker survey for those health workers that were part of the study and utilized the TDAs for more than 10 times. In terms of the settings and study sites, we had about 24 sites across 5 states and the Federal Capital Territory, Kaduna, Oyo, Borno, Enugu, Cross River, and 12 of the sites were primary healthcare facilities, while the other 12 were both secondary and tertiary facilities combined. We had a total of 1,037 children over an enrollment period of 6 months from November 2023 to April 2024. So, like I mentioned before, we evaluated the TDAs in 12 tertiary and secondary facilities on one hand, and 12 primary healthcare facilities on the other hand. And following the initial assessments and decision whether to treat or not to treat for TB in those children with presumptive TB that we evaluated, there was a 2-month follow-up period to allow for the classification of the cases against a standard definition, which is the Graham et al. Definition for classification of cases, whether they are bacteriologically confirmed, whether they are unconfirmed but still diagnosed with TB, unlikely TB, as well as the unclassified cases. Then, of course, the healthcare worker survey to determine the acceptability and feasibility of the TDAs was also conducted. a before and after comparison of TB notification reported from 19 of the research sites was also done from data that were extracted from our routine programmatic reports. So in terms of the performance of the TDAs, following the modified intention to treat that we used after the initial sensitivity analysis, we had to include the unclassified cases. And following that, we had for the TDA, we had a sensitivity of 86.5% and a specificity of 100%, while for the TDA-B, where there is no chest X-ray, the sensitivity was 82.2%, and that the specificity was 99.7%. Both the A and B combined had its specificity of 99.9 and a sensitivity of 87.4%. So just to say that what Sabine presented was the sensitivity and specificity for just the scoring part of the TDAs. But this result has to do with all steps on the use of the algorithm. So it's beyond just the scoring parts. In terms of the feasibility and acceptability of the tools, there were 34 respondents. These were doctors, nurses, and community healthcare workers that implemented the research, and about 12 of them worked in primary healthcare facilities. They all agreed that the TDAs provided timely guidance, and 4 out of 5 of them would strongly recommend the TDAs to their colleagues in other facilities. But just to say that they also had some concerns, which I'll talk about in subsequent slides. So regarding the impact of the TDA, we can see the chart to my left showed the impact of the TDAs both in the PHCs and also in the secondary and tertiary facilities. We can see that for children under 5, there was significant improvement in the notification, both in the PHCs and also in the secondary and tertiary health facilities combined. We can see a dramatic improvement in under 5 notification in the secondary and tertiary health facilities. And also for children between those between 5 to 9 years, we can also see the increase in notification. So we did like an average of the TB notification between November 2021 and April 2022, and November 2022 and April 2023. We did the notification for the 2 periods. We added the notification for the 2 periods and took an average. And what we could find was that within that, from that 2021 to 2023, out of a total of 113 child TB cases were notified over the 6 months period prior to the study. But in the course of the study, we were able to notify 405 children between the ages of 0 to 9 within a 6 months period. So we can see almost close to 4-fold increase in notification in the 0 to 5, 9-year age category. For other age categories, there were also we also noticed increase in notification, but it was particularly marked in this age category. So just to show us that with the treatment decision algorithm, we're able to, sustain some of the efforts that we've introduced since 2023 as a country. And then for the year 2024, we notified about 43,000 children with TB in Nigeria, up from 36,000 children with TB in the year 2023. So again, this is just for the first time we were achieving over 10% child proportion as a country. We never had that prior to this time. We were as at 2017, 2018, we were hovering around 6-7% child proportion. But for 2024, we could see that it's up to about 11% child proportion if we do the mathematics. But again, for DRO-TB, we are not doing too well, even though we increased from DRO-TB in children. We are not doing too well, even though we increased from 98 children with drug-resistant TB in 2023 to 118 in 2024. So again, just like it's been mentioned by Sabine, from the study, we're able to see significant improvement in under 5 notifications. But overall, as a country, we're missing under 5 children. The proportion of 0 to 4 to 5 to 14 is in favor of the 5 to 14 year age group, where we had 75% of the 43,000 children that were notified in 2024 being between the ages of 5 to 14 years. And we really need to work to see how we can, with the use of the algorithms and other innovations, step up case finding amongst the under 5 children. So these are some of the lessons we learned. One is that the TDAs can bridge TB case detection gap in children, even for drug-resistant TB in children. And one significant finding was the fact that from those children that we diagnosed, out of 274 index cases, we're able to diagnose 224 TB cases from contact investigation. The study also showed that it is feasible to task shift pediatric TB diagnosis to nurses and other healthcare workers. But again, training and retraining is needed because they need to be well trained on the use of the algorithms. Regular sensitization of stakeholders on the use of the TDAs. We know that there is still this hesitancy among stakeholders, even among program managers. They do not feel comfortable with the use of the algorithm. So we need to continue to sensitize them and use the results from studies to further convince them that these algorithms are quite effective. Then, of course, there must be job aids for the healthcare workers to make use of. Then the need to simplify some of the terminologies on the TBAs like tachypnea, tachycardia. Maybe we should just say increased pulse rates, rather than, because for those lower cadre healthcare workers, they find it difficult to really comprehend some of these terminologies. For our next steps, we currently have 2 manuscripts on the study that we are working on to disseminate to the larger TB community. We have adopted the TDAs fully. We are no longer adapting. From the findings, it's clear that we need to adopt the TDAs fully. Then, of course, we're working on scaling up the use of the TDAs nationwide by ensuring that we have the SOPs, healthcare workers are trained, and then we continue to sensitize our stakeholders, including the TB partners. The good thing for us is that the child TB response is being driven by pediatricians. They are the ones leading our TWGs. So before we come up with any recommendation, they are the ones to really advise us on the way forward. And because of that, there is not that much resistance from the professional bodies. Then we're also working on implementation research on digitizing the algorithms, which I think will make it easier for the healthcare workers, especially at the lower level, to ensure optimal uptake of these new tools. So I just want to end by acknowledging the following organizations. The Veduta study was funded by TDRO through a grant from the USAID. There is a link to the research package for those of us that want to have access to the research package. We also want to acknowledge the United States government, the TDRO Global Fund, WHO Country Office in Nigeria, the Damian Foundation of Belgium, the KNCV International Self-Feed Project in Nigeria, as well as all TB partners in Nigeria for their commitment in ensuring that we're able to improve our pediatric TB response. Thank you. So for those that will require additional information, my email is here, and I also shared the website of the National TB and Leprosy Control Program for those that will be interested in collaborating with the NTP Nigeria. Thank you.
Okay, thank you, Dr. Uchuko. I will hand it over to Dr. Sabina to co-chair the next session. Thank you.
Thank you so much. Thank you so much, Dr. Uchuko. It's really interesting to see all the different steps that you have taken to implement these algorithms, starting, of course, with a very important role of the technical working group, and then the implementation research, and also contributing to the validation of the algorithms. So that's very interesting.